So let me show you the first example, who is a 50-year-old male who did not have any significant medical history. His history actually included hypercholesterolemia, but he was not on medications. And last time he was seen normal in the previous evening. At 4 a.m. he woke up with right-sided hemiparesis and global aphasia. Now, in a hospital in South Florida, other than Jackson Memorial and now Holy Cross, if this patient goes anywhere else, any other hospital, any other stroke center, what's going to happen to this patient? They will evaluate the patient and consider last time seen normal as the onset of stroke. When did the stroke happen in this patient? Well, according to American Stroke Association criteria, yesterday evening. So the patient passed 8 hours window for intervention, so we cannot even do intraarterial intervention. So what we do is observation and conservative treatment. Now, based on your medical knowledge and experience, what's going to happen to a patient who has a complete occlusion of left carotid artery with global aphasia and right hemiparesis? The perspectives are not too good. But if you have a perfusion scanner, let's do it. We don't know when the stroke happened. Did it happen 9 p.m. yesterday? It might. Did it happen just 5 minutes before the patient woke up? It is possible. Do we know? No. No one will tell us. But the perfusion scanner will be able to give us an estimate what areas of the brain can be still saved and what should we consider already lost. So we did the perfusion scan on this patient, and this is what we saw. Lots of green, a little red here, a little red there, and this scan told us that although we don't know when the stroke happened, we don't know if we are within the 3-hour or 4.5-hour or 6-hour or 8-hour window. We don't know. But we know that we can save a lot of brain. So, let's go ahead with the intervention. We did a quick angiogram. The patient was on the table, in a really short period of time. This is a vertebral artery injection, and you can see a little posterior communicating artery as it tries to feed the middle cerebral artery, but it can't because the middle cerebral artery has a clot in it. You actually see the clot in the artery with this meniscus sign. The MCA is blocked. Simultaneously, if I do a carotid angiogram on the contralateral carotid artery, now this is the right carotid injection, if the blood flow is okay in the MCA, then there would be some flow towards the MCA territory, but there is none. The artery is completely blocked. So now I go for the money. For the left carotid artery, because I know that the left carotid artery is the one that's blocked. And I'm injecting, and the contrast never goes beyond this point. There are two options. Either the whole carotid artery is blocked with blood clot, or actually there is a high-grade and now occlusive stenosis in the carotid artery. And in fact, this was the case because assuming that it's not a carotid stenosis, I went ahead and I used the so-called Penumbra 54 catheter, which is a large bore suction catheter to suction out the blood clot from the carotid, and it never went beyond this point. I couldn't advance it. There's a high-grade stenosis there. It's actually a blocked artery, which I had to pass in order to remove the clot from everywhere else. So first I had to open this up. This is a balloon inflated to 2 atmospheres, and you can see that the low pressure inflation results in a doggy boning or hourglass appearance of this balloon. That's because of the high-grade stenosis in the middle of the balloon. But when I inflate it to 8 atmospheres, it actually opens up. And it took no longer than about 30 seconds. My suction catheter was there, so I just pushed this suction catheter forward, and it's just, and the big line of blood clot just suctioned out from this artery, and in literally 30 seconds, the internal carotid artery was open. Now, here is the problem, because as I know, the MCA is still occluded. So here's the occlusion of the middle cerebral arteries. There is still no blood flow to the rest of the brain. My 54 catheter is there, so I advance the penumbral catheter. Look at the timing here. It is it's in the morning, 7:53:19, and then 7:55, 2 minutes later, the middle cerebral arteries are open. Just need a little suction. There is still a little wedge-shaped deficit there, and let's not do a half work, let's clean that up too. So I went up with a little balloon, and I basically macerated, I broke up this blood clot with this balloon, and the end result you will see. On the way out, I thought I did a good job with the balloon, but I realized that this carotid artery again starts to restenose. It's basically recoiling. And if I don't put a stent in there, then this will occlude again in about an hour or two. So I ended up stenting the patient's left carotid artery. And here is the open left carotid artery. And this is the end result. And this is the patient. We just arrived back to the ICU, and the patient who was previously paralyzed on the right side now can lift the right arm. Not as much as the left, but you know, it moves. Now, let me introduce you. Ron, could you come up? Meet Ron. And I just want to emphasize what we can do in a patient who otherwise would be doomed. There is no TPA, IV TPA treatment that could bring this patient back. There is no way to open up the carotid artery with any other methods. If it is occluded like that, it was mechanically blocked. There is no blood flow anywhere. The only way was to come back from it. Of course, yes, I did probably a good job with this, but I also have to emphasize that this is a teamwork. And the teamwork starts with a person who actually recognized that the patient has a stroke and called 911. Continued with EMS who brought in the patient and did so quickly. And then the doctors recognized that this is a stroke, and then, you know, on and on and on, so that the patient could be discharged from the hospital with an NIH stroke scale. I think 6 days later he had 6 with a little speech deficit. Could you raise the arms in the air in front of you? Close the eyes. Recently, you know, when I was walking on the hallway, I run into a doctor who said, yes, it's nice, but you know, this is an exceptional case, and you know, once in a while, once in a lifetime, and it would be nice to have all of them like that, but it's not possible. That's not true. I will show you that later, but now let's go to the second case. Oh, by the way, this is the follow-up of Ron's CT scan on the second day, and actually there is some hypodensity there. And I want to show you this picture to you. This is the 2-day post-CT scan. Look at where the computer showed the red area on the brain, and look at where the hypodensity showed up in 2 days. And on this other slice, it has a little, I don't know, it's a funny shape. And the hypodensity is that funny shape too on the CT scan. The perfusion scanner actually very well predicted what's going to happen in the long run. Now, how well it predicts, let me show you the second case.